the surgical grand round. It's my great pleasure today to introduce Peter McCulloch, who's well known to everybody. Peter graduated from Aberdeen University, trained in surgery and did his research in Glasgow and became a senior lecturer at Liverpool University. His surgical career has been centered on surgical oncology, originally breast surgery and latterly gastroesophageal cancer. He moved to Oxford in 2004, where he was appointed Professor of Surgical Science and Practice and is still here in the NDS amongst all of us. He is an NIHR senior investigator and runs two research groups within the NDS, the first being the Quality, Reliability, Safety and Teamwork Unit, QRSU, which evaluates methods for improving quality and safety of surgical interventions, and is currently running a 24-hospital randomized trial called RESPOND of a human factors intervention to improve rescue efforts for patients with serious postoperative complications. Peter also founded the IDEAL collaboration, which again will be familiar to us, in 2009 to promote the use of better methodology in scientific evaluation of surgery and other complex healthcare interventions. This group has developed recommendations for an integrated evaluation pathway for surgical studies throughout the lifetime of an operation, and more recently has applied the same principles to guidance for the evaluation of therapeutic devices and, topically, of artificial intelligence in healthcare. They published their paper on evaluation of surgical robots in Nature Medicine in January this year. So once again, it's my pleasure to introduce Peter, and the floor is yours.
Thanks. Thanks very much, James. Good morning, everybody, including the select few who've made it here in person. I'm going to talk today about a kind of overview of patient safety research in surgery. It's been an interest of mine for more years than I care to remember now, but it's still an unsolved problem, and I'm hoping that this may stimulate interest in some younger members of the department in trying to get to the Holy Grail, which we still haven't reached. So I'm going to talk about problem of healthcare safety and how we failed to solve it, and the potential solutions, what evidence exists from the research. The key problem I'm going to talk about today, because it's the one that I've found the most difficult in my research career here, is getting staff engagement with new safety interventions. And the puzzle is why engagement is so difficult in healthcare, when it doesn't seem to be in other industries. How could we improve it? Obviously a good thought. And I'm going to finish with some policy proposals, partly because, given the stage and age I'm at in my career, I am definitely never going to do another trial like the one I've just finished, which I'll be mentioning later. So let's start with the problem. Is there a problem with safety in surgery? Well, when I started my surgical career, the answer was really no. We had a kind of Nelsonian attitude where we didn't see the problem until some publications in the early 90s showed that about 10% of hospital patients were being harmed by their treatment. And this was received with some shock and horror and some simple disbelief. Because we were unaware of it, and our professional ethos was that patients did well because we were good professionals, worked very hard, knew everything we needed to know. And therefore, the corollary, of course, was that when things didn't go well, someone had erred, and that wasn't us. Harm in surgery, harm in healthcare happens one person at a time. So disasters like oil rig explosions and plane crashes don't happen and don't draw everybody's attention to it. So it was quite easy to miss this in a profession where, after all, we're already dealing with people who are ill and have problems. And if we make them iller, it's often difficult to discern that. How big is the problem became quite a big issue in the field. And we had various estimates of this. Again, it may be difficult to understand why it's difficult to measure, but some of the problems are that over time, our ability to measure and the data we've got on healthcare has hugely increased over a couple of decades. Also, we're doing more and more complex things to sicker and sicker people, And when you do lots of complex things to a sick person, fairly obviously, your risks of accidentally causing harm increase exponentially. So trying to get to a figure of how bad the problem is quite difficult. And we have ended up with some fairly amazing suggestions. This is a paper which, this is the original papers on harm. The 10% estimate by Charles Vincent is, I'd still say, the benchmark for the measure of harm. But we did have this extraordinary paper from over 10 years ago now, from Marty Macquarie in the States, suggesting that medical error was the third commonest cause of death in the United States. Now, I think that requires a sort of wake up and pinch me common sense test. And I won't say any more except to point out that Marty Macquarie has now been appointed as director of NIH by Mr. Trump. So this was a sort of wild overestimate. But there is a hidden problem. There is probably a lot more that we could do to improve our results, because normally when we talk about patient safety, we talk about actions which it's clear to see directly harm the patient. What we're all familiar with, and what probably causes a lot more harm, is lack of action or incorrect action, which indirectly harms a patient because it stops us from doing the right treatment at the right time. And that is very difficult to measure, but as I think all of us will reflect on, particularly in emergency cases, it's still quite prevalent. So when we decided there was a problem, we immediately became concerned and tried to find out how to make it safer. A question that arose at that point was, are we really trying to avoid harm, or are we trying to produce better quality? This is a distinction I'd like to emphasize, because if we tackle the problem of patient harm, we end up focusing sometimes on things that are inevitable, like pressure sores in older patients, DVTs, etc. And we miss the opportunities to improve the system. If we look at it in broader terms, in terms of quality, we may be more effective. The idea of the high reliability organization became a very popular theme in safety circles in the early noughties. And things like the United States Navy aircraft carriers were lauded as examples of systems that had incredibly low harm rates from error. And there was a lot of buzz about trying to turn hospitals into HROs. HROs have certain features which are well recognized. They're preoccupied with failure. They constantly think about it. They are reluctant to simplify things and keep things doing things the hard way because it's safer. They're sensitive to operations, meaning they're constantly surveilling what's going on the shop floor, and they're committed to resilience, and they have redundancy of protections. They have layers of defense against errors, and they defer to expertise rather than be the person at the top of the hierarchy deciding. It's the person who's got the skills to deal with the problem on the ground, a principle that the British military also uses widely. Sadly, the HRO concept isn't going to work in healthcare. A very eminent human factors researcher from France, René Amalberti, pointed this out some years ago. All the HROs that we know of which are successful have characteristics that are quite different from healthcare. There are huge numbers of people and smaller numbers of artifacts in healthcare. We're dealing with large numbers of people all the time. It's very complex. It's very unstable. Most of the interactions are between human beings rather than between humans and machines. There's an artisan role. I'm talking about us now, the professionals. There are layers of safety regulations which sometimes do good and sometimes get in the way. So the idea that we can be an HRO, I think, can be dismissed. How good can we get? It's quite difficult to work that out. One of the best ways, I think, is to look at organizations that estimate harm or results, basically. And the Leapfrog group in the United States do this for thousands of hospitals. And looking at their figures, if you look at the top and bottom of the table, probably a real world ambition is to get twice as safe. That's about the difference, 2.0, between the top and the bottom of the scales in leapfrog for morbidity. So we've been doing this for 20 years now. Have we improved? No. Oh dear. This is unfortunately very well documented. The meta-analysis you can see on the right, I know you can't see any of the authors, etc., but it's chronological. And the line down the middle is the median effect estimate at still about 10%, still 10% harm. And you can see there's no trend in the dots and confidence intervals at all. We're staying pretty static whilst others are shooting ahead. And things like the building industry, aviation, even the UK military and oil and gas have had huge successes in the same time span. So what are we doing wrong? Well, looking at the literature and being in the field, I'd point to 4 things that have been blamed for our lack of progress. First of all, we're a very complex specialty. That's true. Some of it is special pleading. But the fact that we, uniquely amongst the professions I've talked about, except the military, deal with a very difficult situation right from the start, i.e. we've got very sick people to deal with. Another thing that we suffer from, which the other organizations don't, is that we never have any time for training. Essentially, the machine must never stop. So training time is at an absolute premium, whereas many other of the professions have time for a pause. The second thing I think we may have done wrong is to look for off-the-shelf solutions from other industries and adapt them without thinking carefully enough about it. And I'll talk about that a bit in a minute. The third thing that's very obvious from reading the literature is that we have had lots of good ideas, but when we look at the studies, they weren't actually implemented. What we intended to do and what we ended up doing were quite different. And the fourth thing, sadly, particularly from my point of view, an academic, is that we've done some of the science very badly. So, sure, yeah. So the complexity of medicine, I think we would all accept as a difficulty, and the relentless nature of the profession. We've done things like adopting CRM, which is the aviation patient safety or safety training teamwork intervention. We've adopted WHO checklist from aviation as well. Lots of things came from aviation in the early days. We've also adopted lean from the manufacturing industry, tried high reliability organizations, etc., etc. In the course of doing this, we've actually invented a new science, implementation science, because we found that it's so difficult to get these things to work in practice. Just to talk about the failures of patient safety science, this is a list of the things that we ought to do that we haven't really done as a community. It has to be stressed that this is difficult work. Trying to make interventions in working processes whilst people are still using them is difficult anywhere, and in medicine more so than many other places because of the additional stress of dealing with sick people. But we have failed to measure things properly. We failed to have control groups, failed to eliminate observer bias. We failed to consider learning curves and actuarial trends, etc., etc. It's been a case for the older aficionados of cinema of the good, the bad, and the ugly. There have been some very good studies, and we've listed some of them here. The patient safety improvement studies in Birmingham about 10 years ago were beautifully done and had a control group, which unfortunately showed that the intervention group got better, but so did the control group. This was done during the Blair-Brown years when we had infusion of cash into the system, and it was a tide that raised all boats. We would not have known that if they hadn't had a control group. Likewise, Improve, a Dutch study that had a similar design and had similar results. Epoch was a study of pre-surgery intervention to stabilize the patient better, for emergency surgery. Very big, well done, large randomized trial, unfortunately found negative result. And then there was the Michigan study of central line infection avoidance in the States, run by Peter McCulloch from Baltimore, which was one of the few studies which was implementable at scale. They first did it at Johns Hopkins, and then they took it into the state of Michigan with success. However, some of the bad science was very influential. There was a huge study of called Med Teams in the Veterans Administration in the US, in which the whole VA was subjected to the aviation-style teamwork training. And they showed a massive improvement. But if you looked at the detail of the methodology, what they did was they evaluated the program halfway through. And they looked at the results of the patient, the hospitals, sorry, who'd already had the intervention and the hospitals who hadn't. And down at the bottom of the methods, there was a vital little sentence that said the hospitals were selected for the program in order of readiness. So they just basically compared the best hospitals with the worst hospitals. So WHO checklist, I'm afraid, is also on the Hall of Shame. If you look at the original WHO checklist study, it's a short-term, open-label, non-randomized, no-control study of an intervention, which was then evaluated by the enthusiasts who'd invented and implemented the intervention. So that would have most evidence-based medicine people squirming in their seats. And the problem with it is that the overestimate of the result has gone around the world. It's been so widely adopted, and nobody actually knows how good it is. I'm sure it does have a beneficial effect, but we don't know how big. This was illustrated by a study from Urban in Ontario in Canada 2 years after the first study was launched, where he compared the mortality results for surgery in the entire state of Ontario in the year before the checklist was introduced and the year after, and the improvement in results was 0. The originators were very upset about this and said, you didn't implement it properly. Exactly. This is the big problem with these patient safety interventions. Implementation is very difficult. So then there is a third group, which is what I guess I would call the ugly. These are commercial organizations that, sorry, I got to go back, that do improvement projects and tend to make big claims, but which do not publish in the peer-reviewed literature. And I've followed up some of these studies, and I've been really quite disturbed by what I found. One of the big companies that's well known is IHI, which has been involved in healthcare improvement in both the NHS England and Scotland. And they've had a bunch of studies, such as the 100,000 Lives studies, the 5 million Lives study, the Maternity Breakthrough Collaborative, and 5 Alive study. I found no publications showing any data at all about their original objectives, except for the 5 Alive study in Ghana, which was about undernourished children and toddlers, where the percentage underweight actually went up in the study group and the mortality reduced non-significantly. And I think, from what I've seen, that this is essentially a scam. We have, of course, tried to learn from some of these lessons, and I'll try and allude to that in some of the later slides. So far, so a bit depressing. What could work? How could we improve safety in hospitals? If you're just thinking about it as a common sense layperson, or indeed as a member of staff, one of the first things you say is more resources. Every time we do our focus groups, that's invariably the vast majority opinion. We need more staff, we need more equipment, we need more time. Unfortunately, if you look at things internationally, we are actually a pretty well-resourced health service. And if you look at the state of the economy, it's unlikely that we're going to get those resources. So I think in the real world, we have to solve this without resources. But there is evidence that the plea for resources is based on fact. During the Blair Brown years, we saw a huge investment in health services and there was a significant decrease in all measures of harm. And there are studies from the US showing about a 26% difference in mortality, depending on the nurse-to-patient ratio between different hospitals. We've had similar studies in Britain of the same kind. Another thing which is often discussed is whether we could change this by changing the management of the service. Health secretaries love to do macro rearrangement and reorganization, but there's also an argument, which I think has some merit, for looking again at the trust model. This was set up, as many will know, in the 1990s to model hospitals after limited companies and to appoint a board which had a predominance of non-exec directors, many of whom had very little understanding of how hospitals work. And certainly in my personal experience, I've seen plenty of examples of where boards have made mysterious decisions that anyone in the hospital could have told them were going to be unfortunate because of that lack of understanding. If you imagine an average board meeting, average hospital, how many people have experience of running hospital? Well, the CEO, the CMO, the chief nurse, and that's it. So the incentives for the board are also very clearly aligned with mainly keeping the hospital's reputation high, keeping the budget stable, and keeping the machine going. These are the three things that they focus on, and the lack of a serious component of senior members of staff on the board, I think, makes them less able to understand what are really the important parts of the organization in terms of operations. I'm not talking about surgical operations now, I'm talking about the day-to-day management. So this, of course, has left us as clinicians bereft of executive power, and sometimes when we're bereft of executive power, we do things that we probably shouldn't do to try and gain some advantages for ourselves, and that compounds the problem. So there's a detachment, which I think we all recognize, between board level attitudes to what's important in hospitals and clinical level. One thing that's very striking in experiencing the work on patient safety is the importance of clinical leadership. A good clinical leader can make all the difference to a project. It's hugely influential. But of course, we don't necessarily give people leadership training. And so it's rather stochastic whether you end up getting lucky or not. Some of these things we can experiment on, but most of these ones we can't. What could we do experiments on to try and find out whether we can make things better? Well, human factors at the frontline level is what I've been doing for the last many years. If you take it up to management level, it's a bit difficult because you can't really replace or retrain boards very easily. Culture change is the other thing that most researchers focused on, trying to make the team work better together. And then again, a challenge to work with is technology. Technology is very important in patient safety, but once more, it's not really susceptible to standard scientific analysis. You have to do observational studies only. So I'm going to talk mainly about frontline studies of changing the system and changing the culture. And I'm going to start with culture because this is where we started many years ago, adopting things from aviation. Their CRM training system had evolved over the years, and they attributed it with success in reducing the number of fatalities. This graph on the left shows this. This is an observational study. There was, of course, no experiment. And the association of the reduction in mortality and crashes and the introduction of CRM may well be fallacious. At the same time, many improvements were being made in communications and avionics. And so the reputation that CRM has as being proven to be beneficial in aviation is, I think, over-optimistic. It's been aggressively marketed by some commercial companies and by some individuals, and there's still a lot of work going on with it in Britain today. And I am not trying to say that it does any harm. How much good it does is a difficult question. This study we did here many years ago now. We got a British Airways aviation trainer and CRM in to work with theatre teams in the John Radcliffe, and we gave them a fairly intensive course. You can see some of the details here. And the things that CRM focus on are mainly about communication and mainly about making sure that staff are clear with each other. We looked at carotid artery surgery and gallbladder surgery at a number of different levels. So we first of all asked people if they liked the course, and they said yes. And then we did a questionnaire which looked at their safety attitudes, which showed they'd improved. Was their behavior changed in theatre? We looked at teamwork scores. Were their working practices improved? Yes, again. We looked at glitches and little slip-ups in operations, and those improved. Were the outcomes improved? No. And this has unfortunately been a consistent message from similar studies around the world. There have been 4 meta-analyses now showing that although teamwork training can be shown to do lots of good things to the team, it's very difficult to prove patient benefit. So we were a bit disappointed by that and decided to look at the system instead. This was work we did in the surgical emergency unit in the John Radcliffe, and it was based on Lean. Lean, as you probably know, is actually called the Toyota production system, except that when it was taken to the States, they couldn't bear to say the first word. So it focuses on, unusually for a Japanese product, a bottom-up approach engaging the frontline staff. It's based on eliminating waste and making error obvious, and it's driven by evidence and data using a continuous PDCA cycle, which I'm sure you'll all be aware of. And the problems are designed out of the system. Sounds great, worked beautifully for manufacturing industry. We decided to apply it to nursing problems, essentially, in the surgical emergency unit. And we selected these 7 problems, I think it's 7, which were commonly on the register of safety incidents. We started by doing a survey to see how good adherence to best practice was across the board. And you could see there was a range of scores, very good for fluid balance, pretty terrible for alcohol gel. This was done before COVID. And then we compared that simple before-after study with compliance with best practice after we'd used Lean on the processes. And again, variable successes, some excellent, like thromboprophylaxis, some didn't work at all, like alcohol gel and fluid balance. When we looked a bit deeper into this, we got some nice p-values, which are, for academics, always enjoyable. The clear correlation was the more you actually did Lean, i.e. the more PDCA cycles you did, the better you got. So it was all about how many PDCA cycles you did, but that in turn was all about how enthused the staff were. If the staff were really interested, it went well. If the staff couldn't be bothered, didn't see the point, it didn't go well at all. And this began to sort of make it clear to us that there was a correlation between the success of quality improvement projects and the cultural issues that the team training was supposed to be dealing with. We did have some very helpful successes with quality improvement interventions over the years, as well as the DVT results. We've done studies on falls in neurosurgery, which we reduced by 50–60%, and in incorrect identification of patients being taken down to radiology, which we essentially eliminated. And we've got publications in both of these. The DVT study was our kind of poster child, because Oxford being a hub hospital, we can easily see who's had a DVT or pulmonary embolus and been through the surgical emergency units. So we had good data to show that we actually achieved at one point, about here, a 60% drop. It sort of bottomed out at about 28% at the end, but that's still very impressive in terms of trying to reduce harm compared to anything else that's been tried with DVT. So we now had evidence that lean works if you do it, and that not doing it seems to be dependent on staff attitudes. And we asked the question, is it better to do the systems thing or the culture thing or both? Our hypothesis, obviously, was it was both. To look at this, we had to devise a fairly complex experiment. We needed to have 5 different groups in the end, each with a control group. And we looked at this in orthopedic theatres across several hospitals, where some of the groups got the culture intervention, the team strengthening program, and some of them, the SOP and the lean, were 2 different flavors, if you like, of quality improvement. And then there were 2 combined groups. So trying to avoid the bad science of the past, very difficult to run, but in the end, we got an answer and it was pretty clear. The answer was yes, both is better. So this on the left is a count of small glitches and the improvement in them over time after the program, before-after comparison. And you can see that CRM and lean comes out best. Again, compliance with the WHO checklist, now that it's compulsory, is a very neat, easy way of measuring whether people are complying with what they ought to do, even if you don't know the benefits of the WHO checklist. So these results were the first in the field to show that combining a systems intervention and a culture intervention was synergistic, and probably that should be standard of care. However, it reproduced the experience it had in other studies, that the big problem was staff engagement. And that is the main focus of my talk today, because it has been the elephant in the room. In all my time in doing this kind of research, it's very little talked about at patient safety conferences, but if you talk to people on the side, they all agree that it's the major drag on the system. So we're now doing a study called Respond, which was intended to try and put all of this learning together. It's based on trying to improve rescue processes for deteriorating patients after emergency surgery. So that's a serious problem. We all know about that. It's a step-weight randomized trial based on a progression of earlier studies. So we did an observational study to look at the problem. We did focus groups with staff to try and help co-design the interventions. And then we did a pilot study in 3 hospitals. And we've taken a bundle approach, as in not doing just one kind of silver bullet intervention, but trying to attack the escalation process for patients who are deteriorating at various points. And we devised an engagement strategy based on the fact that we recognized this was the biggest problem. This is a schematic of the Respond intervention bundle. So we have a patient involvement strand, giving patients access to the CCOT directly. We had shared ownership was a method of getting very junior doctors to communicate better using a template, again, borrowed from aviation, I have to say. Enhancing the escalation procedure, using a card system to remind everybody of what they were supposed to be doing in an emergency, and a team strengthening program where we diverged completely from the aviation model and did something else instead. What we did was to go to experts in forming teams whose jobs essentially required them to be successful. So people who trained military teams and people who trained elite sports teams. And we had some great fun with this, because we managed to get luminaries like Dan Carter, the captain of the All Blacks. We interviewed him, Lewis Hamilton's pit stop captain, the head of the Army Leadership School, and the Chief of Staff of the Royal Marines Training Depot. So really top quality people, and remarkably consistent in their views on what made a good team where people really wanted to work for each other. Some of the things they said were that people needed to socialize together, train frequently and intensively together, difficult one in hospitals, but we substituted observed practice. Celebrate success and good performance, so be very positive about our wins. Buddy and mentor, have symbols and rituals that mean something to everybody. Eradicate cliques. And one of the key messages, look to the either the senior players in the team or the non-commissioned officers in the military to maintain the culture so that the constant churn of staff doesn't eradicate the intervention. So our engagement strategy was the other novelty of Respond, and here we relied on some more traditional sources. Everett Rogers was the man who wrote the book Diffusion of Innovations, explaining why some things take off and others don't. And he championed the idea of the early adopter. He pointed out that when new things arrive, there's always a small group of enthusiasts who take it up immediately, but they are the same group of enthusiasts who take other things up immediately, and other people don't necessarily follow them. It's when the good professionals who are middle of the road people take it up that everybody else wants to come on board. So the message was, let's find these people and make them the champions for our cause. We had Roberto Cialdini from the world of advertising. He and Rogers had a lot of very sensible things to say from extensive research about how you engage staff, mainly based on their own self-interest. So we had Dale Carnegie, whose psychological insights into persuasiveness are now about 100 years old, but still very valuable. And of course, not to make it all positive, Machiavelli, who points out some very important things for people who are trying to do systems change, like asking yourself who benefits from this and who's going to be harmed, and how can you avoid problems from the people who see themselves as being harmed. So some of the obvious things that these people told us was the innovation has to have some obvious personal advantage for people. It has to be easy and cheap to adopt. It has to be adopted by respected peers, so that's the early adopters. It has to need to fit with the local culture, and it needs to be flexible. It needs to be customizable by the staff so that they can refine it to their own ends. So that was the engagement strategy, and it was based on co-design with the staff, making it fit with their values and practice, making it easy and customizable, tying it to personal benefits, and employing the early adopters. We tried to create support through away days using some of the insights we got from the teamwork training experts. And we applied all of this in part 3 of the program, which was the pilot study in 3 hospitals. And this is the summary result. The Richard tool, the tool we designed for communication by juniors, was universally well accepted. The emergency cards were mostly accepted without too much trouble, likewise the teamwork training. But the problems we had were with the patient involvement strand and the champions. The champions unfortunately failed completely because we underestimated the power of hierarchy in the hospital. We took people who we thought were enthusiasts who would be influential because of their experience and good reputation, but they weren't in charge. And we found that that ultimately made them unable to bring about the change. The patient involvement strand had problems of a different kind. Essentially, we found that the idea of making the patient able to directly communicate with the CCOT was deeply unpopular with a lot of nurses who felt that this was undermining them professionally, and they voted with their feet and didn't engage with the program. Despite a lot of vicissitudes like this, our results in terms of mean response time to emergencies were highly significant. This is epochs 1, 2, and 3. This is before, during, and after the program. And this was just at the end of the COVID epidemic. So we were actually pleasantly surprised to find that we'd made a significant difference. But the engagement problem still loomed large. And we looked at this and decided to do some studies of well-known examples of institutional failure in healthcare. And we saw that the reports were really very similar to each other. There's a remote management focused on numbers, not quality. time pressure, tough targets, financial constraints on staff. This will be familiar to many of you, and a lack of external oversight. And this leads to a culture of fear, hierarchy, blame, untouchable people, tribes and silos, disaffection, and burnout. And these reports have been published in many contexts over the decades. It's always the same pattern. The question that fascinated us was, well, why? How does a culture made up of well-meaning people who have a vocational interest in trying to help other people end up doing this? And we used the 5 whys technique from Lean, essentially repeatedly interrogating the data to try and get to the bottom of this. J. Edwards Deeming, management expert, said this about systems. Every system is designed perfectly to get the results it gets. Think about it. And if you look at the NHS systems, what they're essentially designed to do is to keep the machine running at 110%. And the way in which hospitals are structured, according to one very well recognized business model, is strictly in the hierarchy corner of this model. So this means there's a lack of training and expertise in change management, because we're not about change management, we're about keeping the thing going. And the responsibility for safety and qualities tends to get diffused. If we look at culture, which everybody always quotes as a big factor, it's interesting, and we've tried to base our approach on a fairly deep reading of the literature and looking mainly at qualitative studies, but finding pretty clear evidence for a model of culture which we're still in the process of developing. It starts with what I mentioned, the vocational attitude of people who go into healthcare. We want to help other people, and we're generally trained in a person-centered model where your own personal virtue and hard work are very important in achieving success. You then start work in a workplace where you find that things are very hierarchical and often quite uncomfortable in that respect. And you become aware of a governance system which can be quite punitive if you're involved in any untoward events. And then for neophytes to the system, the added factor is that there's a lot of stress around. It's a very stressful job being a doctor or a nurse, and you see bad things happen and you're involved in them. And the biggest problem that I think most people have in healthcare is their inability to do the job as well as they wanted to do it, because of the constraints on resources, time, etc., and the hierarchy, etc., etc. So you end up feeling very uncomfortable. And what happens when you feel very uncomfortable like this? Well, people react in various ways, but some of them are very similar to us, familiar to us. There's the famous culture of fear, there's guilt and shame, desperately trying to keep the machine going, driving and bullying yourself and others, hiding, blaming, and lack of accountability at the top, which is unfortunately prevalent in our system, just like it is in many others. But lack of accountability at the top is very important because it allows people at the top to behave irresponsibly. So when we look at this model, and as I said, this is all based on a fairly intensive literature review, we can begin to see why engagement with the sort of work we've been doing over the years is pretty difficult. One of the side studies we've done, which I haven't mentioned, is to look at communications and decision-making in hospitals and compare that with private hospitals and with local councils. And we found that we're pretty bad compared to them at both of these things. So that makes it hard to change things. The hierarchies, silos, and so on make change risky and stressful. The culture that's engendered when we're under pressure is one that becomes very inward looking and very resentful of people who come along from outside to try and help, even if they are established professionals in the same field like us. And so it's quite difficult to persuade people. And staff usually have experiences that suggest to them that change management in hospitals doesn't work. Hospital boards are always very happy to praise patient safety initiatives, but providing them with real support is rare. And of course, the incentives for people who decide to be leaders in this job are pretty scanty. People like consultants, people like ward sisters who want to take this on find it's just an extra task on top of everything else, which is going to get them into lots of hassles, and nobody is going to thank them for it. So as they say in Liverpool, why would you? A lot of people do because they're vocationally motivated and want to make things better. But it's a c'est fait, as they say in Scotland. And one of the people I interviewed about this said, well, you know, the thing with intervention by research, as you do, versus following management directives is a bit like the difference between listening to a street preacher and getting a letter from the HMRC. You may be more enthused and sympathetic by the, to the street preacher, but you're definitely going to do what the HMRCs tell you. So this rather bright graph, I'm slightly colorblind, and my partner told me I should put sort of more pastel colors on this, but didn't have time. Sums up where we are at the moment, and we are actively engaged in some qualitative work to try and fill in some of the gaps here. But you can see that frontline culture is really the core of the problem, and there are positive factors like leadership and vocational values alongside factors which are largely negative at the moment, which drive this. And this has fallout effects in terms of fear, learned helplessness, and a bunker mentality, which inhibit frontline engagement. In the meantime, as I said, parallel research we're doing shows that decision-making and communication in hospitals could do with a lot of improvement. So what do we know from all this? Healthcare safety could be better. The profile of management behavior and staff culture in failing hospitals is pretty consistent. And senior management in the current trust model have very different priorities and perspectives on how hospitals run from clinical staff. The systems and culture factors are understood, but we don't have quantitative measures of how important they are. And frontline systems interventions can work, but usually only if they're limited in scale and restricted to particular areas. And frontline engagement is the big one. It's the final common pathway for success. The influences on this: communication's difficult, decision-making is very slow with multiple stakeholders, and this makes staff very cynical about the possibility of positive change. And the professional culture that we're imbued with actually has a potential adverse effect when we're under stress in producing some of the negative behaviors that we've seen. And as I've pointed out, initiatives by groups like us are heavily reliant on motivated clinical leaders and are not going to get anywhere in terms of transforming the system unless they have much stronger real management support. We still don't know what the optimal dose duration and delivery for these interventions is. We don't know how to reliably generate frontline engagement, but we're using the model I've just shown you to try and attack some of the causes of disengagement. And this is going to be the focus of our future work. And how do we sustain this in the long term? My last slide, really, as I said, I feel I've got the liberty to give you some views based not just on my research, but experience about what could make safety in surgery and in hospitals generally better, and what it would cost. I've alluded to my critique of board management. I think if their incentives were different and the composition of the board was different, hospitals might be run in a much more effective and safer way. And I think any future initiatives have to be owned by the board with external scientific management from people like us. Two important areas for research on what could improve things are radical improvement in trust communications, which I think we're going to be publishing soon, showing how poor they are, and devolution of authority to clinical teams. There's a model called Boortzorg in the Netherlands, which has been very successful in giving clinical leaders a budget, some management support, and a lot more autonomy in running their own show. And this has been actually cost efficient as well as improving working lives and clinical results. Whether that can be transferred from the community basis where it's currently being used to hospitals is an unanswered question. The external review of safety incidents, we had great hopes for the Health Services Investigation Board, but it has rather lost its way and been absorbed into CQC. I think we need to reverse that. And people who are going to get into senior positions of management and authority should have some change management and systems thinking. The doctor-nurse barrier is still a very important issue at the junior levels. And I think that a period of training together during their during their first degree would do an awful lot to break down attitudes that I see forming very, very early in the junior staff. And changes to the medical legal environment could help us. One of my previous projects was to try and train the GMC in human factors. Unfortunately, that was hijacked by COVID. But we did identify that the key people who need training are not the investigators, it's the medical experts. So I think that concludes, if you like, a grand tour of patient safety research and why it's an unsolved problem and why engagement is the key. Thank you very much for your time.